Well, welcome to Longevanity. We're just going to go live in our streaming software here, and then we'll get started momentarily. Thanks for joining us this afternoon. Here we are. We are now live. Perfect. All right, we'll get started. So, just to begin, thank you so much for joining us on another episode of Longevanity, the intersection where healthy longevity meets aesthetic, live your best life. I'll be doing our discussion today. I'm Amber Bocknek, a physician in Aurora, Ontario, with a focused practice in both non-surgical aesthetics as well as longevity medicine. So today we're going to have a very interesting topic. I was asking my staff this morning again, what have they been getting a lot of questions? And lately, a lot of questions have been coming in around sexual health and well-being. So as we come into the holiday season, a little gift to yourself and the one you love can perhaps be a little bit of additional enjoyment. So we're going to chat about some of these somewhat controversial or potentially taboo feeling topics today. But before we dive in, very important always to know that podcasts and educational content like this is really deemed just to be that educational content. It is to spark conversations, and hopefully with some of the things we cover today, this will bring up topics of conversation that you can talk about with your own primary care provider, the one who knows your medical health the best. And so today we're going to cover some broad reaching topics. And these again are general health content without knowing your specific needs. So please take everything here in the way that it is intended, which is to be educational, to spark educated conversations, to arm you with material that help you advocate for yourself and ultimately, of course, live your best life. So with that said, we're going to chat about the very broad world of sexual health and wellness and enjoying some of those intimate moments. So in our practice, we see both women and men. And there are a number of different reasons why people can present with some of these issues. So let's maybe look at vignettes of different types of clinical presentations, and we can use that as a touch point to talk about what some of the common presenting symptoms would be and what some of the various treatment options are. So let's start first, maybe our first vignette. Let's pick sort of a quintessential maybe later 50s female patient. And I'm picking later 50s specifically because I'm trying to select somebody who's probably already gone all the way through menopause and hasn't had a real period now in maybe 5 to 10 years. And so with the loss of hormones comes a whole lot of physical change. And we're going to talk about physical changes as well as some of the psychological factors to consider too. So on the hormone side first, we'll talk about hormones from the biochemistry, and then we'll talk about the structural issues, the urogenital, and then we'll talk about the psychological. So on the biochemical side, we've got everything that's happening with the hormones. With menopause, we see really massive declines in the amount of estrogen and progesterone produced in the body. They fall quite precipitously, as can also testosterone and DHEA. Now, just to be really clear, for those of you who don't know, all human beings actually have the same sex hormones. So all humans have estrogen, progesterone, testosterone, and DHEA. And you heard me correctly. I mean both men and women. So, yep. The guys, they also have estrogen and progesterone, and the ladies, we have testosterone as well. So we have all these hormones in human beings. We just have them in different proportions by our gender. So again, these things should be there. So on the hormone side of things, involved in just libido as well as the health of the gynecological tissue, we do have the hormones. So classically, we think of testosterone as the hormone of drive or libido. So this is true. Testosterone does contribute to libido in women. Testosterone of its own has a host of additional factors for women. So testosterone is really important in body composition, in the amount of lean muscle mass that you have. In addition to that of the role of estrogen and progesterone, testosterone serves a role in bone density and strength of bone. Testosterone, we have receptors for testosterone pretty much all over our body, including our brain, and testosterone has a role in cognitive function. So it helps with mental clarity, mental fortitude, it does a host of different things, and yes, it helps with libido. So that's part of it. But libido for women is complicated. So libido is actually driven by a host of different factors. And if you struggle with libido, testosterone might be part of a very diverse population of contributors to the libido issues, but it is one of several contributors. Libido for women is also highly affected by mental state. So stress level, sleep, cortisol, emotional factors, and connection, very important with women. So if, again, you're having difficulty you're finding around libido, we really want to look at you as a whole person, not just whether you need testosterone, yes or no. It's not quite so straightforward. We want to look at your testosterone needs, yes, but we also want to look at your daily level of stress. If you're getting enough sleep at night and enough restfulness, do you have good emotional connection with your partner? All of these things also play a role. So again, libido and desire, complicated, multifactorial, but testosterone does play a role. From there, let's move down the pipeline, so to speak. So let's talk a little bit about urogenital changes. So with the loss of estrogen and progesterone, we can see some thinning and changes in the urogenital tissue. So let's talk about the vagina. In the vagina, in the premenopausal state, especially in early adulthood, the lining of the vagina has all kinds of little ridges and folds called rugae, and they allow for stretch and elasticity and for the ability to expand during childbirth, but also to make intimacy more comfortable. The vagina is what we call a potential space. It's not just an open tube. It's closed or it's collapsed on itself most of the time, other than in childbirth, intimacy, inserting a tampon, all those sorts of activities. So it has to be able to stretch to accommodate. So when the hormone levels fall, we see major changes to the mucosa or the lining of the vagina. So the rugae or the folds really diminish quite significantly. And if you were a woman ever who was on an estrogen antagonist, say you had breast cancer and you were on some anti-estrogen types of medication, you can see very considerable advanced thinning and loss of that elasticity in that area. So that is part of the intimate experience. If things have really thinned out and aren't as elastic and supple as they were, it can make intimacy very uncomfortable. It's kind of like trying to be intimate with a hairbrush, not appealing. So the ability of the vagina to respond with elasticity is really important. Another very important role of the vagina is to be able to provide intrinsic lubrication. So again, with the loss of natural hormone, as we see already in minor and increasing amounts from perimenopause all the way through menopause, that interferes with the vagina's ability to lubricate, again, making intimacy more uncomfortable, more friction. Again, ways to work around that. We'll talk about some procedural things, but again, water-based lubricants and the like can sometimes be helpful, as can, again, hormone replacement. We'll chat about that too. So again, we have structural elements with the thinning of the vaginal walls. We have functional elements with the ability to lubricate. So these are definite things that can happen. We also can get thinning out of the labia minora, and again, just changes at the external environment. And again, thinning and changes of the skin in that area is one of the contributors to why women become increasingly more prone to urinary infections. So this can all be part and parcel. Now, there's a number of different things to consider for you to talk about with your primary caregiver if you're experiencing these things. So one of the categories of care is to ask about what the new thought is around appropriate hormone replacement therapy. So we are becoming more and more aware of, again, the benefits of body identical or bioidentical hormone replacement. So sometimes that's given systemically, so the whole body gets exposed. And sometimes it's given more regionally or just topically, just to the vagina and the external genitalia, which can be done. But hormone replacement, if you're a candidate for it in that area, can be life-changing. So again, from a sexual point of view, it can help with the intimacy experience by improving some of the health of the mucosa, again, to stimulate it to become thicker, plumper, more supple, more able to lubricate. That's all very helpful. Also, it can help reduce some of the incidence of developing urinary tract infections. And there are actually a number of different hormones we can consider in that area. Sometimes you can use vaginal suppositories or vaginal rings that can stay there for a while, topical creams. We use estrogen, we use testosterone, and sometimes we use the other hormone called DHEA. And these things can be applied or taken in different ways in that area. Or again, sometimes we treat the whole body, the whole person with these hormones to try to help with the context of all of that. So this again is what we have as far as the biochemical part of it. Now, on the physical side, there are some physical treatments. Say again, there's a lot of lingering fear around hormones, unfortunately, all due to some very unfortunate misconceptions from the Women's Health Initiative study that came out in 2002. And they still linger today. Some medical professionals still are hanging on to that study and have not yet gotten comfortable again with how we're looking at hormones now and why that study was erroneous in some of the conclusions we drew from it. So if you have a lot of fear around hormones, there are other things we can consider to try to make the mucosa and the pelvic floor healthier. So one of the options is actually doing these chairs that have electromagnetic energy. So this is a very comfortable procedure, not at all like a pap test. In fact, you are fully dressed. You sit on a chair fully dressed, and for about 30 minutes, the chair releases electromagnetic energy. It's if you're not familiar with these energy sources or terms, electromagnetic energy is the same type of energy as what an MRI makes, but it's being applied here a little bit differently. So most people who are a candidate for an MRI, most of those people are a candidate for this as well. So this is utterly non-hormonal. And it's also utterly non-invasive. So if you're a little shy, or again, you really hate being instrumented, this is something you can consider. So it actually creates fields of energy that does several positive things. It makes the muscles of the pelvic floor contract, like doing Kegels, but in a way you've never done Kegels before. You do around 13,000-ish Kegel-like contractions in 30 minutes. So it is like super mega workout. And that helps with the pelvic floor for a couple of things. So it's very helpful again for holding the pelvic floor in its best position, which again helps to support the uterus, the vagina, the bladder. If you have issues around urinary incontinence, sometimes it can be immensely helpful for that as well. Actually, we use it as a treatment for that, for those purposes, for the right patients. So this is these electromagnetic chairs. They come under different brand names. There are a couple. They have wonderful evidence behind them for effectiveness. And again, the majority of people who can have an MRI can use these chairs. Things that would preclude you from an MRI also would preclude you from being a patient for the chair. And just some quick ones off the top of my head, but keep in mind there are still more. So educational, you need to chat with your doc. Are things like implanted electrical devices. That's a huge no-no, like a pacemaker or an implanted electrical defibrillator or an insulin pump that you can't take off. For people who have continuous glucose monitoring and a pump that we can remove, we can work around that in our office. We simply have you do your change day for your glucose monitor on the day that you come in for your chair session. You take it off, sit on the chair, pop the new one on, and Bob's your uncle, out you go. So these chairs can be very helpful. So they make the muscles contract. And that's the thing that people feel the most when they're sitting on the chairs. And again, that strengthens pelvic floor, helps to lift and maintain good pelvic posture, which helps to support the bladder. And it helps for those who kind of have a oopsie moment when they sneeze or cough, which is if you passed a little human out of there, there's a good chance you might have a bit of that. So it can be very helpful for those issues. The other thing that we note that happens with this type of energy is that this type of energy really helps to create a situation where a very specific substance called nitric oxide, which we make in our bodies, which is a vasodilator, it stimulates your body to make more of that, and that helps to dilate the little blood vessels. That's a good thing. Why is that a good thing? It's a good thing because it increases local tissue circulation. So we find that, again, one of the things that happens just with the loss of hormones, as the tissue thins out, the blood supply to the area kind of regresses as well. So these chairs can be helpful to stimulate endothelial and the production of nitrous oxide, which helps the blood flow. So that's helpful for lubrication and responsiveness. So there's a lot of improvement in the experience of the intimate moment. So it makes it a lot more comfortable and more pleasurable. And that actually works for both genders. So in women, it tends to help with vaginal responsiveness. In men, it is something we can use to assist with erectile issues, again, because an erection requires a healthy circulatory system, and also with the experience of actual climax. So very helpful in both genders. And both genders have, again, some of these changes as hormone levels fall. So again, this is the pelvic floor chair using electromagnetic energy, or the chair treatment as we call it in our office. Another thing that we can use to work in that area to try to help, sometimes we do resurfacing with a CO2 laser. That helps to, again, stimulate the mucosa to turn the mucosa over. You may have heard of CO2 lasers for facial resurfacing, and we do the same thing on the face. So the vagina is a slightly different tissue. It's a mucous membrane, but it's a skin surface, and so it can also be treated with the laser. Now, this is very PAP-like, as you can imagine. And so this can help to stimulate that area as well, again, without the use of hormones if you're someone who happens to still be nervous about that, or again, under consultation with your own physician, you felt that that wouldn't be an option for you. So this is another option. A third thing that, again, can sometimes be helpful for some people, I don't know if you've ever heard about the O shot or the P shot, but these, again, are natural processes that are procedures that are meant to stimulate your body using your own growth and healing factors taken from your own blood to stimulate you to make new natural blood vessels from yourself. So it's a you for you process trying to help stimulate you to, again, make new blood vessels and, again, make that tissue healthier. So in this procedure, the O shot or the P shot, we do a blood draw from your arm. We take your blood, we spin it around in the centrifuge, we separate out the plasma, which is the sort of straw-colored protein liquid that carries the platelets, and the platelets release a lot of growth factors, and then we, with a very, very fine needle, super fine, re-inject that into the delicate areas that are affected by change to try to stimulate them to become healthier. And this is done with a healthy dollop, if you're not allergic, of freezing cream first to try to get you super numb, and then from there a little bit of injected freezing to make you super duper numb. That's my very medical term. And then from there the plasma goes in. So that's what an O shot and a P shot is. So on women, an O shot refers, of course, to the clitoris and the G-spot area in the vagina. In men, the P shot, it's for the penis. So again, delicate regions done delicately. So these are these sorts of treatments. So the other thing is these things can be done in combination. So where somebody is a good candidate for hormone replacement, we can combine hormone supplementation in balance done the correct way for that specific individual, and then align them with perhaps a physical treatment, whether that be chair for pelvic floor and again blood vessel stimulation, whether that be laser resurfacing to try to turn over some of the mucosa, or whether that be the O shot or the P shot or multiple combos thereof. So each person is unique and different, and their experience with intimacy is different, and the background help that they bring to the table is different. So using each person's individual variables, a very customized plan can be made. So it is a complicated thing that can be broken down into these various components, and then we can put it together. I think one of the most important things to note is that the best care is personal care. So this is really where you take a look at your own personal history, your own health history with risks and family history and things you've tried before, successful, unsuccessful, for women a full gynecological history, and then again from there trying to put something together that's very specific. So in this situation where we have a menopausal woman who's lost all of her hormones, we would be considering all of the above: her psychosocial context, the stress in her life, her health history, her feelings around hormones, and then again her gynae history around types of deliveries she had, whether they were vaginal, C-section, did she tear, did she need a vacuum or forceps, was there a lot of trauma to the vagina, are there residual problems or prolapse, and then we can put together a full program. Now, for other women who are younger, let's say premenopausal or early perimenopausal, sometimes their hormones aren't so much at play. A lot of times, especially if women have had very large babies, or they're a very small framed individual and they've had a normal sized baby. The analogy I use is pushing a football through a garden hose. So when you have these things happen, if you've had a little human come out through there, then again, sometimes even if the hormones are normal, we have some distortion to the pelvic floor. And again, these women may not need necessarily hormone supplementation, but then they still may need some of the structural support like the electromagnetic energy chairs, or perhaps again, a little bit of the resurfacing, the O shot, the P shot. So sometimes we look in those situations to some of these physical treatments to try to help them. For men have male menopause. The correct name for that is andropause, but theirs is more andro slowing down, where women is like this abrupt stoppage. There's like this crazy period beforehand that we call perimenopause, but at some point everything just kind of stops. So it's very abrupt. With men, they gradually decline year over year in most situations. Again, there are some differences between individual to individual, but the majority of the time it's the slow, steady decline. But as that decline happens, again, they experience changes as well in their body. So for men, you can see, again, changes in testicle size, differences in libido, ability to achieve an erection can become more difficult. The firmness of the erection can be difficult to attain. Being able to have an orgasm can also become harder and not as strong or robust as once it was. So again, in some situations, we want to look with men too, if they're in that age where we see decline, well, where are their hormones at? Now, on that line and on that about age, lower levels of testosterone are not only in middle-aged men. We are seeing populations of younger men, and by younger, I mean late 20s and early 30s, what we would classically consider prime of life younger men who may have lower testosterone. And there's a number of different theories why that might be happening, but one of the culprit theories that we consider is something called endocrine disruptors. So endocrine, referring to the glandular system of the body, which can be all the glands, including sexual hormone function. There are chemicals in our environment that we're using quite a bit in the last 20 to 30 years that have shapes chemically that are very similar to some of our sex hormones. And what happens is hormones interact with receptors like a lock and a key. So they have to fit to make the receptor, like to turn the lock in the analogy, or to make the receptor do its function. So these chemicals that have a very similar shape to the natural hormone can sometimes occupy the receptor. Now, it's not exactly the same as the hormone, so it doesn't produce the hormone effect. But if it gets into that receptor, it blocks that receptor from being able to respond to the actual hormone, because it's like if you had your lock jammed. You can't get the key in, you can't turn the lock, you can't make it function. So this can be part of the problem, and they can antagonize the hormones that are out there. So we're seeing these younger men who are also presenting with symptoms of low testosterone. So for the guys, again, absolutely it can affect libido, but they can have other changes as well too. Their energy can be much less. Their motivation and their drive can really fall. They may feel flustered and anxious, and this background angst feeling, which again, there are other things that can do this, but this is one of the possible features of testosterone. So again, we can have these psychological things, we can have these urogenital things, we can have body composition changes. They are losing their muscle mass. They're putting on what we consider female fat distribution. They're putting on weight around their hips. They may be getting breast development. There was a whole Seinfeld episode, if you remember those Seinfeld episodes in the 80s, about the man's ear. Again, guys don't feel comfortable with this if they're not transitioning. So this is something to be sensitive about. So sometimes, again, we can see these imbalances with these endocrine disruptors that can cause this. Sometimes they can have normal levels of testosterone, but excessive levels of estrogen. Remember, men should have estrogen too, but it needs to be at the right amount, the right quantity, and in balance. And endocrine disruptors, A, can mimic estrogen, and B, can create a situation where, again, it changes body composition, where they're putting weight on and body fat in the fat itself. In men, it can convert testosterone to estrogen, producing these effects. So we have to consider all of that in men too. So in men's health, hormone balance and hormones are also critically important. So these are some of the things to consider. It's just not so straightforward. So if you're looking for a little more information, we do have some information on our website, on the chair, on the lasers, on the O-shot, the P-shot, also around hormones for men and for women. So I would encourage you to check us out there. And if you enjoy our podcast, we'd love to have you subscribe and follow. This is something new that we've been adding. And in time, I'm going to start bringing on some guests that will talk about some of their area of expertise around some of these different topics. Right now, while we're small and new, you just get me. But I'm always interested in hearing about what you want to hear about. So you can reach out to me. You can follow us on our socials. We're on Instagram and Facebook. And if there's something you want to hear about, please message me with your questions, and we'll make that a podcast topic, because I'd love to chat about that more with everybody. Because if you have questions about it, you got to know other people do as well. So with all that said, again, just to wrap up, thank you so much for your time and your involvement today. And just remember, these are discussion points and are not meant to be taken as personal advice, but please feel welcome to reach out to the person you trust the most for your health to get your personalized information. And thank you again for watching another episode of Longevanity. And we'll be here next Wednesday at the lunch hour, same